I'm Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. I hope everyone is doing well and staying healthy during the pandemic. Today, I'm pleased to have Dr. Margaret Ma and Dr. Manjari Lahiri from the National University of Singapore. Doctors Ma and Lahiri are, along with co-authors, Doctors Tay, Cheung, Santosa, Chan, Yip, and Mac, wrote an article entitled Attitudes and Behaviors of Patients with Rheumatic Diseases During the Early Stages of the COVID-19 Outbreak. This article is now available on the journal's website at jrheum.org. So Drs. Mon and Lahiri, I want to thank you for writing the article and for agreeing to discuss this topic, especially with the time change between Canada and Singapore.
Thanks for having me.
Well, thank you.
For having
me. So we'll move right along. And either one or both of you, let me know, can answer any of the questions. Okay. So what do you think are the most important lessons to be learned from the early time with COVID-19, as in many countries, we're now hitting a second wave?
Okay, so maybe I should take the lead on this one. So we like this, the paper's entitled the early phases. Although obviously at the time we did the study, we didn't realize how early a phase this would be because it's been quite a prolonged process. But essentially, late February, early March time, when we realized that COVID was really going to be hanging around, we wanted to send out a survey to all of our rheumatology patients to assess their attitudes of the pandemic and how their behaviors have changed. So we sent a survey out by SMS in an anonymized fashion to all of the patients that have attended our service within the previous year. And I think the first thing I learned pretty quickly is that from a personal point of view is that how quickly things can be done during something like a COVID pandemic. Because it was COVID related, everything was expedited and we were able to get ethics approval within 1 week, which was unheard of. So I was super impressed with that, even with Singapore efficiency. And from the patient's point of view as well, they were very engaged because this was obviously something close to all their hearts. And we managed to get over 2,200 replies within just 2 weeks. So we were very pleased with that, with those results. So that's what I learned personally, just from a researcher point of view. From the actual study itself, obviously all our patients from the survey were worried about catching COVID and worried about going out, and worried that either or that the disease can increase the risk of catching COVID, but also the medication could increase the risk of catching COVID. But despite that, our patients actually very well behaved in general, and only a tiny proportion of patients did actually reduce or stop their treatment. Most actually stayed on treatment, which I thought was fascinating. So even though they were worried, they still carried on and were compliant according to the survey. And what the other interesting finding I thought was that the attitude towards face masks, which has become increasingly controversial as the pandemic has evolved. And during March time, when we sent out this survey, so despite the government at the time discouraging use of face masks when patients are well, nearly 50% of patients that replied to the survey just said that they admitted to wearing face masks even when they were feeling well. And as obviously the pandemic has gone on, this is now in stark contrast to the rest of the world, where there seems to be more of a anti-mask movement in a significant proportion of the population, despite now face masks being recommended, mandated, but in some areas certainly highly recommended worldwide. So, and then the last thing I wanted to highlight in terms of the study is that we wanted to use an unbiased approach to analyzing this data, and we used a latent class analysis to look for clusters of patients that behaved in similar ways. We by using latent class analysis, we were able to actually group patients into 3 groups. One of these groups, which we named C3, were deemed the most worried about catching COVID. And their behaviors were that they contacted the health care workers more, but also they were more likely to reduce treatment as well because of their worries. And the socio-demographics of these population is that these were all more women. There were more rates of unemployment, and they belonged to the non-Chinese ethnic minorities. So with the study, we were able to highlight a group of patients that perhaps needed more support. So I think those were some of the salient points of the study that I thought were important.
Maybe I'll just add on to the method of the survey. So it was a time when we were actually discouraging patients to come to hospital and we were cancelling appointments. So just the method of doing the survey, like Margaret mentioned, we did an SMS thing. So a text message went out over the course of the day. So over the course of a few hours, we sent out 5,000 text messages. And this was to be done in the context of data security with all the privacy maintained. And in Singapore, our healthcare system is actually cut off from the internet. We have internet separations. We kind of had to surmount the internet separation, get the survey out, get them to do the survey and populate the results in a hybrid cloud and bring it back. So we're very grateful to the Academics Informatics Office for helping us with this, which they managed to do at really short notice. So literally from the conception of the idea to actually getting ethics approval and doing the survey, it was, I think it's the fastest study we've ever done within a couple of weeks.
Yeah, I was impressed by the speed and how you get it done so quickly, but it was Singapore, so it didn't. So next question. In the article, it stated you did a survey before Singapore had its lockdown. Do you have any information at all about beliefs since the lockdown, or now it's many months later with potentially, certainly, I haven't heard about Singapore, but many other parts of the world, the second wave is now coming.
Yeah, Singapore is actually doing quite well, but I think we were quite lucky and quite fortuitous to do the survey early on, where we could actually gauge the behavior and attitudes, because soon after that, a lot of rules came in. So at that time, like Margaret mentioned, face masks were actually discouraged, and yet a lot of patients were wearing them. Now face masks are mandated, so we can't step out of the house without wearing face masks. So you have to wear it and you don't have a choice. For a time, there was something called a circuit breaker, which is similar to the lockdowns in other places. So in April and May, there was the lockdown, so social interaction was not allowed. Travel is still strongly discouraged, so there's a travel advisory. So we were able to survey patients at a time when they chose not to travel and chose not to go out and socialize, whereas now I think a lot of the behaviors are driven by the rules. The other thing, of course, that's happened is that time has gone by, so we're, I think, in general, as a population, much less worried because it's less of an unknown. At that time, it was a new disease. Singapore bore the early brunt of it before the US and Europe got affected. We had it quite bad in those days in March and April, but things have settled down. So people are more familiar with it, and the situation in Singapore is now very, very controlled. So we're having single digit or even zero. There are 0 cases today of local transmission.
Oh.
Yeah, we're doing well. So it's been in the single digits all of October, and we've had at least a few days when there's 0 local transmission cases. So I think in general, for at least the patient perspective, patient part of view, not socially, there's still lots of restrictions, but for the patient point of view, coming for consults, I think patients are much less worried, much more willing to come in now. We have noticed that perhaps patients are more conscientious of keeping their appointments. So there used to be patients who miss their appointments, want to reschedule, whereas I think they're a little bit more health conscious perhaps. There's less resistance to vaccinations. A lot of patients decline vaccinations for the flu and for pneumonia. And now patients are a bit more willing to accept vaccinations. So it's a bit of a positive impact. Margaret, anything to add?
No, I certainly echo what Manjari said. So now, because there's so many restrictions that is mandated by the government, certainly, behaviors somewhat formulaic. And so if we were to do this survey now, I think we would definitely get different answers, but I don't think perhaps it will be voluntary from the patient's point of view.
Right. Of course. So it's very interesting, I read your article that only 7.4% of your patients actually sought advice about COVID-19 from healthcare professionals. Do you think that it was on our side that we could have done a better job as physicians or healthcare professionals as a whole, not just physicians, allied healthcare professionals, of getting the word out as we saw it, or did we just leave it to the government, or did we just not know? Certainly at that point, and we didn't want to give unknown advice, look stupid or whatever, because nobody really knew what to do.
Yeah, you're right. So I think at that time, when we're looking at all the literature, there was, barely any guidance from any of the international societies on what to do. And we were very much, looking at the government for advice on just general behavior, general prevention of the spread of disease. And yes, it is a small amount, it's a small percentage, 7.4%. And I guess it can be interpreted two ways. It could be interpreted that actually they felt well informed enough not to contact us, perhaps, if you want to look at it from an optimistic point of view. But obviously, it could be that they just didn't know how to contact us, or and we certainly could always do better. And since our study had started, the chapter of rheumatologists in Singapore that Manjari is the chair of, they did actually publish guidance online regarding COVID for rheumatology patients. So there was one online resource. Obviously, you have to actively go and look for that. But we certainly could, be more active in approaching patients as well. And our study did highlight a profile of patients that perhaps we should be prioritizing and trying to reach out to try to alleviate some of their worries. So yeah, I mean, now I'm sure everyone now using telehealth, telemedicine, so that would be a great way to certainly contact patients that perhaps are more reluctant to come to hospital.
Yeah, I mean, I think it took us a bit of a while to get onto the telehealth platform, so it wasn't something we routinely did. So initially, of course, the first reaction was to cancel appointments and postpone them, but then you realize that you actually can see your patients virtually. So certainly, if next time there is a need, we probably don't need to cancel, and we can actually still see our patients without having them come into hospital.
Yeah, I mean, this is just an aside. I think one of the things that's certainly come up in North America is, certainly a lot of physicians I speak to, is that telehealth isn't so bad. That we do a lot via telehealth in our rheumatology patients, and maybe we don't have to in person see them quite so often as we do. So there might be something good about this for our patients too. And
the Manjari and I were actually today just discussing the behaviors of clinicians and how obviously COVID has changed our attitudes and our beliefs as well, and that telehealth is something certainly that we're all embracing now and very accepting of. That's interesting.
And everything. Policy as well, so we wouldn't have been reimbursed for televisits previously, whereas now we.
Yeah.
That's the big thing, and that's what's going to change. Telehealth, I guess, will survive if governments and insurers in other countries can keep on reimbursing people for telehealth. We shall see. So table 3 in your paper was comparing patients into two groups where it was a connective tissue disease, inflammatory arthritis, using immunosuppressives, and those who didn't fit into the category. So to summarize for people who haven't read the article, what were the important differences you believe between these groups?
So maybe I'll just clarify. It was so in table 3 we have the whole cohort first, so all our patients, which is 2,200 plus patients, and the second part of it is the subset of patients who had either inflammatory disease or connective tissue disease or were on immunosuppressants. So that's about 1,500. So it isn't really two groups; it's a whole cohort and then a subset. In general, not very different. So we did a latent class analysis separately for the whole cohort first, and then for the subset. And patients clustered into 3 groups depending on what answers they gave in the survey. So the more anxious ones tended to go out less, wear face masks more even when it wasn't encouraged, but also tended to sort of default on their medicines or be less inclined to get vaccinations. And then there were the less anxious group, which were not into those kind of behaviors. And interestingly, the thing that distinguished the groups was not what disease they had. So it wasn't like patients with lupus were more anxious than patients with gout, for instance. It was the socio-demographics. So it was women, those who were from an ethnic minority, non-Chinese. Chinese is the majority ethnicity in Singapore, so the non-Chinese ethnic minority, and those who were unemployed were the ones who tended to cluster in cluster 3. In the subset analysis of those with inflammatory disease or connective tissue disease, where we thought this question would be even more pertinent because these are the patients on immunosuppression or who might think because of their condition they're more sort of susceptible to severe disease, it was pretty much the same, except that we did see a little bit of a difference between the inflammatory arthritis and CTD groups. So in connective tissue disease group, they tend to cluster more in the less in the cluster 3, more in cluster 1. Sorry, the other way around. More in cluster 3. They were more anxious, whereas the inflammatory arthritis group tended to cluster more towards the less anxious cluster 1 group within that subset. But overall, it was pretty much similar. That is, the women, unemployed, and those of the ethnic minorities.
Yeah, I found that really interesting, that the disease per se, whether what we would have considered higher risk, didn't seem to matter by attitudes.
And the non-inflammatory things like osteoarthritis and osteoporosis, you really wouldn't think would put people at risk, but they pretty much behave the same as someone with lupus on immunosuppression.
Yeah, I thought that was a very interesting point. And so finally, as we conclude, did we miss it? Did I miss anything? Anything either one of you would like to add for the people who haven't read it, encourage them to read your article?
Well, obviously, we encourage everyone to read the article, and it was a brief report, so I think we've covered most of the points in this.
Okay, so I want to thank you both. It was an excellent article, and I thank you for agreeing to speak with me. And I encourage everybody to please read the full-length article, Attitudes and Behaviors of Patients with Rheumatic Diseases During the Early Stages of COVID-19 Outbreak by Doctors Ma, Tai, Cheung, Santosa, Chan, Yip, Mack, and Lahiri, as well as all our other articles about SARS-CoV-2 infection and COVID-19 and its effects and implications for rheumatologists and in rheumatology practice at www.jroom.org/COVID-19. If any comments or questions, please let us know either via Twitter at jroom or email us at manuscripts@jroom.com. And thank you all for joining me, and everybody stay healthy. And thank you, Dr. Lahiri, again.
Thank you very much.